for the introduction. Happy to see you all. Very good afternoon to all. As Senior Ma'am said, today we are going to learn about ostomy care. So this is another nursing issues in palliative care. You have also seen in your settings many ostomies, colostomies, tracheostomies, gastrostomies, and all. Let me share my screen. Is it visible to everyone?
Yes, ma'am, it's visible. Yeah.
Okay. So I know this today also we don't have a case presentation. So there are two different types of ostomies in which we have seen. There are input ostomies and output ostomies. So input ostomies are tracheostomy, gastrostomy, feeding ileostomy, and output ostomies are colostomy, urostomy, and ileostomy. These are the two different types of ostomies which we have seen in our settings. So let me start with the patient story. So can anyone please read this patient scenario? Anybody?
Requesting any of our participants to kindly unmute and voluntarily please come forward to read this. Please.
Mr. Raman is a 35-year-old gentleman. He was diagnosed to have carcinoma colon 2 months ago. He underwent proctocolectomy and ileostomy followed by chemotherapy. He has now come in the OP accompanied by his wife with skin excoriation around the ostomy site. He looks tired, agitated with poor skin turgor. His wife says after the surgery, he is angry and upset.
Read. Please continue.
What could have contributed to him developing skin excoriation? Why is he angry and upset?
Okay. Thank you. So here, as one of you read, is a 35-year-old gentleman diagnosed with the carcinoma colon 2 months ago. He underwent protocolectomy and ileostomy, followed by chemotherapy. Now, his main complaints is excoriation, skin excoriation around the stoma. And he looks tired and agitation, poor skin turgor. His wife is also accompanied with him. He is coming to OP. My question is, what could have contributed to him developing skin excoriation? What could be the cause of developing skin excoriation? And why is he angry and upset? Please share your thoughts. Please put your answers in the chat box. Anyway, we don't have a patient story today. That is why I prepared a patient story. So we can discuss. I will wait till your answers come. Please contribute your thoughts. If you have seen these type of patients in your settings, so the patients complaining of skin excoriation around the ostomy site, and he's very anxious and angry about his problems. So what is your what you will do and what you can identify. So what is your thoughts? Okay, if we see some kind of patients, we might be thinking, oh, maybe due to this, maybe due to that. That kind of thinking in our minds comes first. So that is why I'm asking. So what could be the cause of skin discoloration for this patient?
There is 2 chats.
Yes, please share. Yeah, I'll look into it.
Okay.
So one is Nirosha said irritations. Again, mentally feels that he wants to remove the infections in his skin. I think so.
Imperfection in his skin.
Imperfection. Okay. Oh, imperfection. Okay.
Before that, there is also 2 chat like itchy around the site
Thing
and
around the site. Yes.
irritation also.
Okay. Any other answers? Why? Oh, so my question is why he developed itching? Why he developed skin excoriation? This patient is ileostomy, having ileostomy, and he developed skin excoriation. That is the main reason. And after that, he is anxious and angry. Ileostomy is too large. One of you said. Any other answers? What does it mean? Ileostomy is too large. Any other answers? No. Might be due to dry skin, which leads to itching. Sorry, I mean ileostomy bag. Okay, thank you. Okay. So thank you for the contributions. Okay. First, so we all know that
Excuse me, Sheeba ma'am,
the
we
parts.
lost you for some time. Sorry, ma'am. We lost you for some time.
Okay, can you hear me now?
Yeah, it's audible.
Okay, fine. So there are 3 parts of small intestine. One is duodenum, the second one is jejunum, and the third one is ileum. So if you made a ostomy into the ileum, we call it as ileostomy. Okay. So let's see what are the functions of small intestine. So what are the functions of small intestine? Can anyone please say what are the major functions of small intestine? This is related to small intestine. That is why I am asking what are the major functions of small intestine? Anybody? Digestion, absorb nutrients, any other answers? Okay. So extract water. Okay, thank you. So as you said, there are many functions of the small intestine. So I'm going to share the few the major functions of small intestine functions that receive digestive enzymes from the pancreas and liver. So that way, that breakdown of food with digestive enzymes and make it more digestible. And the third one is absorb nutrients. As one of you said, absorb nutrients is one of the major that function of small intestine and help to maintain the balance of fluids. It's absorb water, like especially electrolyte like sodium. It will help to absorb water and sodium. And then after absorption of nutrients and the electrolytes, that will move to the food from the small intestine to large intestine for further absorption. And again, one more role is help to fight against the bacteria. Okay, these are the major functions of small intestine. Please keep it in mind. We need to discuss about the patient story, related the patient story. That patient is also made a ostomy in the small intestine. So it has affected in the small intestine. So these are the major functions of small intestine. So what is a stoma? So we all know that stoma or ostomy is an opening. So stoma is an opening that connect the body cavity to outside environment. So if we create a stoma, it look like this. So usually it's a pinkish color. If there is a good blood supply there, it look like a slight pinkish or a slight reddish color. So if we created a stoma in the outside body, it look like this. So whenever the bowel is moved, we all know that whenever the bowel is moved, the fecal matter will come out. There is no control in the bowel. So that usually after the digestion, that fecal matters go to the rectum, and once the rectum is loaded, that signal goes to our mind, and then we go to the toilet and think that we need to defecate the stool. Then our sphincter will be opening, and then we defecate the stool. No, so this is the normal way. But here, what is happening? So the bowel is, we cut the bowel, and that part will move, that stitch out, pull it out and stitch outside the body cavity. Okay, so that time, whenever the bowel is moved, the fecal matters will come out through that way. So what we usually do is we connect a colostomy bag over the stoma and collect the fecal matters through the colostomy bag. So what are the sites? So one is ileostomy. We all know that this patient is also having ileostomy. If we made a ostomy into the ileum part, we call it as ileostomy. And based on the tumor area, we created a stoma. Okay, so if we made a colostomy, colostomy into the large intestine, like we all know that large intestine have four parts: ascending colon, transverse colon, descending colon, and sigmoid colon. These are the four parts of large intestine. If we made a colostomy into the ascending colon, we call it as ascending colostomy. And we made a transverse colon colostomy, we call it as if we made a ostomy in the transverse colon, we call it as transverse colostomy. If we made a the colostomy in the descending part, we call it as descending colostomy, and then a sigmoid colostomy. Based on the sites of the stoma, we call the different names. So this is very, very important. So the nature of output is different from the different types of stoma. Okay, and the problems are different. So sometimes the ileostomy patients have more problems than a colostomy patient. Sometimes the few problems will be different from a ileostomy and colostomy, and from the different parts, the sides also. So the nature of the output is different, and the problems also different, and the management is also different. We need to understand this is important one. So come to the ileostomy. We all know that ileostomy is the small absorption, that large portion of the digestion is happening there, and absorption of nutrients and the electrolytes takes place in the small intestine. Here, what happened? Usually 500 to 1300 ml is that usually output will be there at up to 1500 ml, and they can also develop electrolyte imbalance. So here, the sodium and potassium loss is more through ileostomy. Here, before absorption, before happening a good absorption, that fecal matters go out. Okay, so from the ileostomy, after digestion, after absorption of the small intestine, that fecal matter, that indigested that fecal matters will goes to the large intestine, and there also some sort of absorption is there, especially sodium and water absorption is major role in large intestine. Here, this patient is having is also developed. If the patient is having ileostomy, that patients could be developed an electrolyte imbalance. Okay, and higher concentration of digestive enzymes. This is very, very important, that higher concentration of digestive enzymes that can leak into the normal skin can cause skin excoriation. Okay, that patient is having ileostomy and with the complaints of skin excoriation, may be due to higher concentration of digestive enzymes, the digestive enzymes leaking through the normal skin. That could be the cause of skin excoriation for the patient. And excessive water loss here. So before absorption of water, absorption of full water from the intestine, that fecal matters will go out. It will be collecting with the bag. So there could be a chance of excessive water loss. So if there is a excessive water loss there is a chance of developing dehydration and renal stones. So these are the major problems the patient is having ileostomy. And we know that patient is having anxious and angry. So we will discuss later on that. Okay. So now we understand that the patients, that ileostomy patient is developing skin excoriation might be due to high concentration of electrolytes that digestive enzymes leak into the normal skin, may be the reason. And now we move on to the colostomy. Okay, so colostomy, this is usually we have seen many patients in colostomy. So colostomy is an opening created in the body along with the remaining fecal matter from the large bowel or colon. So this is it's a colostomy. If the patient is having tumor, depends upon the tumor, tumor size, we create a stoma. Okay, here might be this patient is having colostomy on the sigmoid area. Here might be the chance of the patient develop rectal mass or rectal tumor or CA rectum. So that time what we will do is we create a sigmoid colostomy, stoma on the sigmoid colon, and from that part. From there, we will collect the fecal matters into the bag. So here, as I already said, there are 4 parts of large intestine: ascending colon, transverse colon, descending colon, and sigmoid colon. So we need to understand that what are the features of the fecal matters into the each part of the small intestine. Okay. 1 minute, 1 minute. So here the features that matter, the fecal matters, the features of fecal matters is very different from the each part. Okay. Here ascending colon, if the that fecal matter, the consistency is output is liquid and acidic, that and unpredictable output will be there in ascending colon area. Okay, so if we made a colostomy on the ascending colon, so that output is liquid and acidic, and also unpredictable output is also there, because there is a lot of water contains into the that fecal matters. There is that the anytime the fecal matters will come out. And coming to the transverse colon colostomy, that liquid from that area, the fecal matter is liquid to semi form, and here also unpredictable output is there. Okay, so here the third one is okay. So third one is descending colon colostomy. Here also semi-formed to completely formed stool is there, and output mostly predicted. Okay, you have seen there where this actually the stoma is made. Here descending colostomy colon, and finally the sigmoid colostomy stool is always that formed and can be predictable. Okay. So the problems faced by the patient with the stoma. So we have to understand that what are the problems faced by the patients if the patient is having stoma. So when a patient comes to you with a stoma, you have to do the proper assessment. So what are the things you need to assess for that that patient? So the first one is skin excoriation. So we need to identify the cause of skin excoriation. If the patient is complaining of skin excoriation, first we need to identify the cause. So peristomal skin reaction, you have to identify the cause. It could be the chemical cause. Okay, so you have to identify whether there is a chemical cause, or whether there is a mechanical cause, or whether there is a microbiological cause. Okay, so if there is a chemical cause there, you have to think about what is the chemical. Actually, if we apply the stoma barrier cream before that, maybe that might be the reason for peristomal skin reactions. So that is also you have to think about, and also some leakage. And the second thing is mechanical injury. Mechanical thing is, so before if you are not protect the stoma while we remove the stoma, the stoma barrier, that stoma wafer or a base plate from the skin, if you are not give a special attention on that area, there might be a chance of mechanical injury. And the third one is microbiological. That could be the cause of fungal thing, the fungal infections, because of the leakage or wetness. Wet, if there is a wet there is a chance of getting fungal infection. So we have to identify the cause of skin excoriation first. And the second thing is stoma prolapse. So usually the few days after surgery, that some sort of edema will be there. But if there is a large stomal prolapse there, you have to, what you can do is you can do a manual reduction by a trained person. So as a nurse, you can lubricate lubricate your little finger with the silocaine jelly and try to insert the bowel into the inside, and you have to try to pull the intestine inside the stomach. So that way we can able to that manage. If too much prolapse there, you have to send the patient for a to the surgeon. Okay. And the second thing is stomal retraction. So if there is a stomal retraction there, we are not able to fix the bag properly. That is the cause of stomal retractions. So that time, what you can do is we have a converse pouch system, like usually we get the this type of bags. So that could be helpful for this type of patients. Otherwise, leakage is the major problem. If you apply the normal base plate on that area, that ostomy area, that is not fixed properly, and there is a chance of leakage of fecal matters through the that improp that not that fixed area, that there is could be a chance of leakage. And and the third and the fourth one is stomal stenosis. So here is a narrowing of stoma. If there is a severe stenosis there is a chance of developing the abdominal cramps also. That means as a colic type of pains will be there. So these patients will need a surgical corrections. You have to send the patients as soon as to the surgeon for further attention. And the last one is constipation. And here also inadequate water intake can cause constipation. And so for an inactive stoma, 4 to 6 hours if the stoma is not functioning more than 4 to 6 hours, that could be a chance of the patients. After that, the patients could develop abdominal cramps. And I already said that patients need medical attention, and you can use stimulant laxatives also. If they don't have any problems like stomal stenosis or any other problem, you can give a stimulant. Only the patient is complaining of constipation, so you can give a stimulant laxatives or stool softener for emptying the bowel. And also develop peristomal hernia for some patients. If there is a peristomal hernia, there is also the patients can develop pain, and better you can send the patient to the surgeon. And also bleeding. So there is a when we take care of the stoma, there is a small oozing out of blood will be there, but the bleeding is not stop with your pressure. If there is a small bleeding there, you can apply a local pressure. That bleeding is not controlled, you can refer to the patient to the surgeon. So come to the colostomy appliance part. We all know that there are two different types of colostomy bags are available. One is one-piece method, and the another one is two-piece method. One-piece method is one that stoma protector, that barrier layer is there. When you open remove the that layer, protect layer, and directly apply on the they're directly fixed on the stomal area. So once the bag is filled, you can remove the entire bag and discard the bag along with the fecal matter, throw it away. And but if you are using the two-piece bag, there is a base plate or wafer will be there. You can able to attach a colostomy bag on the wafer. Okay, whenever the fecal matter is filled, you can go to the toilet and remove the bag from the wafer, and discard the fecal matter into the closet, and clean the the bag and allow it to dry. Okay, then they can able to fix a new bag. Okay, so that is the difference between the one-piece method and a two-piece method. So how can we changing the pouch and skin barrier? How to apply the skin barrier cream? So whenever we remove the that old base plate from the colostomy site, ostomy area, try to avoid mechanical injuries. So mechanical injuries is one of the major problems. So always try to avoid mechanical injuries. So how can we try avoid mechanical injuries? So whenever we remove the old base plate from the skin, you have to push the skin gently around the stoma. Then you can remove the wafer smoothly, and you can give a you can take a warm water for removing the old base plate. And once the barrier is removed, you can clean the area with the warm water and pat the area, not apply too much pressures. You can always try to dry the area with patting. And so while applying the skin barrier, you have to measure the stomal area, the stomal size is correctly. So we have a stoma gauge. There is a stoma measuring gauge is also available if you purchase one colostomy kit. You can also, along with the kit, that colostomy guide is also available. With the help of colostomy guide, you can able to measure the size of the stoma. So you can see the measurement, how the measurement is taken. So after you take the measurement, you have to take a base plate, and you can see that picture. You can you can mark the first. You can mark the base plate. Okay. So when you mark the base plate, that opening should be a little bit more than the normal size. Okay. If you are taking the correct size of stoma, there could be a chance of that the stomal edges will be irritating the stoma, and there is a chance of developing bleeding. And if the size is too large, what happening is, when the fecal matter is coming out from the bowel, that will be leaking touches or leaking into the normal skin and developing skin discoloration. So that the stomal size is whenever we cut the base plate, that the stomal size is you have to cut it correctly. So after you take the measurement, you have to cut the base plate little bit more the larger than the normal size. That is approximately 3 to 4 mm larger than the normal stoma. Okay. So after taking the measurements, what you have to do is you can cut the that ender part, after marking the area, that part you can cut it. And there is a protective cover is there, that you can remove it from the wafer and apply on the stomal area. So after apply the base plate on the stoma, then you can apply you can fix a bag on the base plate. Okay. So there is a locking system there. You can after the fixing the bag on the stoma, you can lock the colostomy bag like this. So we'll show a video later. That time you will so understand more about that. So and come to the colostomy diet. Here there are no absolute the dietary restriction for a patients with colostomy. There is no dietary restrictions. only the patient is having such kind of problems, not symptoms, problems there like odor and constipation or loose stool there, then you can suggest a few things, not stop that kind of foods. They can control that kind of foods. So here you have to keep it in mind when if the patient is having ileostomy after eating. So if they ate that 2 hours before, maybe after eating 2 to 4 hours, that first bowel empty, you can expect. Okay. And if the patient is having distal colostomy, that patients will having that fecal output that 6 to 8 hours. So so if the patient is having ileostomy, that could be that patients will develop much earlier than the distal colostomy patients. Okay. So here the cabbage, garlic, beans, and fried food may cause odor. So these kind of foods can cause odor if the patient's complaining of that bad odor, the foul smell, they are not tolerating it. That family members are very irritating when the that fecal matters will come out. So there's some kind of very small order is that kind of complaints there. So you can advise the patient to control these type of foods. Okay, not stop. They can control. These are the food items which can cause bad smell. So better you can control these type of foods. And if the patient is having constipation, you can suggest corn, nuts, cabbage, vegetables, peeling. That is also can cause hardening of stools. So sorry, stool. So here you can educate the patient for same. Here and also if the patient is having diarrhea, coffee, fruits, and fruit juices and oils, some kind of foods that oils will produce that diarrhea. What we suggest here is we suggest they can use the same oil for cooking. So sometimes the different kinds of oils can cause diarrhea. So better they can use the same oil for cooking. And here that sometimes that enteric coated tablets is not absorbed completely. So that if possible, you can avoid that kind of tablets. For travel, work, and sports, so patient with colostomy can travel any like any other person. So they can. So what they can do is they can carry extra bags. That is the one thing. The next thing is so when we travel, the other passengers doesn't know whether the other person is having stoma or not. So better they can that go with a purse or a small bag like that. Whenever they travel, that public they can take a public travel. They can protect the stoma with the help of a purse or a small bag. So that way they can able to protect the stoma. And here one important thing we can suggest is that all other routine works they can do, but they can keep it in mind, try to avoid heavy lifting and strenuous exercise like that. And so these are the important things. And the another thing is avoid contact sports that can injury, that can maybe there is a chance of developing injury to the stoma. That kind of sports will be avoided. So the coming to the second case scenario, can anyone please read this case scenario? Anybody?
Case scenario 2.
Hmm.
Mr. T, 45 years old, was diagnosed with carcinoma rectum and had undergone epi resection and sigmoid colostomy 3 months ago. He had been using disposable colostomy bag for bowel emptying. He is a management executive and finds it very difficult to manage it. Number A, what option can you advise him as a palliative doctor or nurse?
Okay, thank you. Thank you. Okay, so here, as you read, here is a 45-year-old man diagnosed with a rectum and undergone sigmoid colostomy 3 months ago. He is using colostomy bag for bowel emptying. It is very difficult to manage because he is working as a management executive. So he is very difficult to manage the colostomy bag. So what options can you advise if a patient comes to you and tell all these problems? So what you will suggest for this patient? Any answers? Anybody?
We can talk to the patient and explain explain that he doesn't have any other option anyway. He has to manage it. Then we can help him to adjust his mind to adapt this role. Then we can give him some options to take separate to arrange some place or some arrange some specific time to change the bags, and likewise we can advise him to if possible we can advise him to arrange his routines to adjust with these issues, and we can show or we can introduce some peers with the same situation and how they manage.
Okay, thank you. Any other options? We can listen their worries and advice, give advice and give psychological support to the patients. That is what Nirosha was saying. Any other options? Anybody?
There is a chat.
Okay. Check the site of stoma. Check the size of the bag and choose the right one. Okay. He is using the right size bag and right. He's using the right bag, but he's very difficult to manage. He is working, and whenever the bowel is moved, the fecal matters will be collecting with the bag. So that he need to empty in between his working time. That is the problem. He needs to work. Any other answers? Okay. So here, this patient is having sigmoid colostomy. Okay. What is the type of fecal matters in the sigmoid colostomy? Sigmoid colon? What is the type, the features of that fecal matters? Is it liquid or formed stool? Nirosha said semi-solid in the sigmoid colon. The sigmoid colon, usually the formed stool will be there. After the sigmoid colon, that fecal matter, yeah, fully formed stool is there. That after when the fecal matter go to the sigmoid colon, then it will go to, from the sigmoid colon, it will go to rectum for emptying. Okay, so here is a formed stool is there. So here we can give one option called colostomy irrigation. Okay, so what you can do is you can suggest colostomy irrigation. I don't know how many of you heard about this and how many of you have this experience, colostomy irrigation. This is the options we can suggest for these patients, especially this patient is having sigmoid colostomy, formed stool is there. We can irrigate the stoma, and so after irrigations, 6 to 8 hours, the bowel will be free. Okay, so as I said earlier, if the patient is having ileostomy, after 2 to 4 hours, the bowel emptying will be there. But the patient is having end colostomy, 6 to 8 hours after eating, 6 to 8, then 6 to 8 hours will be safe for that time. Then only the the fecal matters will be there. So you can suggest colostomy irrigation for this patient. So when we suggest colostomy irrigations, what are the things we need to suggest? So what are the purpose? So if you irrigate the bowel, we can able to establish the regular bowel habit. Okay, so this is the first purpose of colostomy irrigation. The second one is we can clean the entire colon of gas, mucus, and fecal matches. Okay, so that formed stool we can introduce that lukewarm water and irrigate, wash out all the fecal matters, fecal mucus and all from the intestine, so that the bowel will be free. And that the third purpose is to prevent skin excoriation. So if we do this colostomy irrigations, that fecal matters will wash it out, and 6 to 8 hours that bowel will be free. There is no chance of bowel movement, and there is no chance of leakage. So that way we can able to prevent skin excoriation. And if the patient is accept colostomy irrigations, you can use plain lukewarm water for irrigating the bowel. And what are the instructions you can give for that patients? So this is very, very important. Whenever you suggest colostomy irrigation for that patient, that time the patients might be thinking, okay, once in a week or once in a month we can do colostomy irrigation. Nothing like that. You have to instruct. If they accept colostomy irrigation, they have to do it as a lifelong. Okay, and irrigate daily at a fixed time, so that way we can able to develop habit formations. After within 21 days, we can able to develop habit formation. Okay, this is colostomy irrigation. So what you can suggest is colostomy. If you do the colostomy, if the patient is accept colostomy irrigation, you can take there is a colostomy irrigation set is available. Colostomy also colostomy, the long sleeve is also available. You can like a IV set. There is a colostomy irrigation bag is also there. You can collect that bag. You can you can collect the lukewarm water. Okay, so initially you can start with 1,000 ml. You can start 1,000 ml of lukewarm water and remove the air from the colostomy irrigation set. Then hang it in the shoulder level of the patient. Okay, the patients can sit in front of the toilet and then also they can connect a long sleeve along with the that colostomy appliance. And after introducing the 1,000 ml of after how you can insert the that there is a cone is also the in the colostomy bag, and there is a cone shape that part is also available. That part you can lubricate with silicone jelly and introduce into the insert into the stoma, and then you can open the regulator so that all the 1,000 ml of water go inside. And after inserting all the water, you can remove the colostomy bag from the colostomy irrigation cone from the stoma and wait for return flow. So within 20 minutes that all fecal matters will come out, will wash out. Okay, so after that they are if they want, they can use one colostomy bag for for safety. Sometimes when some fluids will come out, usually not happen, but if they are working, then maybe if they are working persons, better they can use it. They can apply one colostomy bag, and also nowadays the colostomy adapter is also available. If they want, they can use a colostomy adapter for closing the stoma. So that way we can able to do the colostomy irrigation. Once you do the colostomy irrigation, the all fecal matters will wash out, and after 6 to 8 hours the bowel will be free, and they can go for work, or they can no fear in between the fecal matters, whether the fecal matters will come out or not. There is nothing worry about that. It's absolutely 6 to 8 hours the bowel will be free. But the thing is, only the patients having sigmoid colostomy and ascending colostomy patients can suggest colostomy irrigations, but all other persons is not using colostomy irrigation, because the fecal that type, that ascending colon and transverse colon, that fecal matter is slightly liquid and acidic, and there is no need if you apply if you insert a water again lose stool, and the another thing is only 2 to 4 hours will be lasting. So if the patient is having sigmoid colostomy and in the descending colostomy, you can suggest colostomy irrigation. So now we can watch a video on colostomy care, and then move on to the tracheostomy care. Okay.
Is an opening created in
So I hope okay, thank you. I hope you have cleared about that. So move on to the next part. The screen is visible to everyone.
Yes, ma'am, it's visible.
Yes, okay, thank you. So next we move on to the tracheostomy part. This is as I said in the beginning. So there are two different types of colostomy. One is input ostomy, and another is output ostomy. This is under is the input under the input ostomy, that is tracheostomy. So if we have any tumor into the large lower part of the upper part of the trachea, so we made that opening into the trachea. That way we can able to that create a they can able to breathe. Okay. So tracheostomy, we all know that tracheostomy we can is an artificial opening made into the trachea, which the tube is that once we made a opening into the trachea, that that through that opening we will insert a tube for establishing and maintaining a pattern airway. So usually after tracheostomy, the patient is having tracheostomy tube into the tracheostomy site. So we all know that there are three different parts of tracheostomy tubes, and the two different types of tracheostomy tubes are available. One is vortex tubes, and the another one is metal tubes. The vortex tubes usually, so if we create the initial period, like 3 months after surgery, we used vortex tube for maintaining the pattern airway. After 3 months, if the patient is having permanent tracheostomy, after 3 months, we usually go for a metal tracheostomy tubes. Okay. So, so usually the patients will come initially in the beginning stage, the patients will come with a vortex type tubes, and but later on it will change to metal tubes. So it has outer tube, inner tube, and an obturator. So outer tube, we all know that it held in place with the by a ribbon ribbon or tie should be that should be tied around the neck of the patients. That should be there in all the times that for the outer tube. For the inner tube, which is inside inserted inside the outer tube, that can be easily removed at any time, and washed it and remove that mucus from the inner tube and reinsert. Okay. And the another tube, another one is called obturator. We always said the patients, please keep it safe for a obturator. And if there is any accidental displacement there in the outer tube, we usually use obturator for guide the stoma. So when we insert the inner outer tube into the tracheostomy area, we need to use that obturator for guide the opening. So that is the three parts of the tracheostomy tubes. So coming to the inner tube, so what you can do is always you can train the patients about the tracheostomy care. Okay, with the help of the mirror, they can clean the inner tube. So what you suggest is the cleaning of inner tube is very important. Anytime they can remove from the from the inner outer tube and clean it. There is a chance of lot of that mucus accumulated in the inner tube that we need to clean it regularly. So what they can, if they are using vortex tube, we are not able to boil it, but that time what you suggest is they can remove the inner tube from the vortex tube. That if they are using vortex tube, they can same thing, same way they can remove the inner tube and clean it under running water, and make sure there is no mucus inside the inner tube. And if there is a thick mucus secretions there, they can that soaked in a normal saline. After that, they can again clean under running water. If the mucus is inside, if the mucus is present inside, you can use suction tubes for cleaning. Okay, you can insert the suction tube or small tubes like nail cut, a piece of that any tubes you can use for cleaning the inner tube. After cleaning under running water, again you can wash with normal saline and tap well. Make sure that there is no water is inside the inner tube, and then you can replace the inner tube into the outer tube. Okay, that way we can change it. But one important message we need to convey with the patient is within 5 to 10 minutes they need to replace the inner tube. Once they remove the once they remove the inner tube from the outer tube, there is a chance of blockage of outer tube with the maybe due to thick secretions are there. There is a chance of blockage of outer tube. So that we need to prevent it. For that, whenever they remove out inner tube from the outer tube, they clean it as soon as possible. Within 5 to 10 minutes, they have to replace back. And if they are using metal tube, the same way they need to clean, but some few things is different than a vortex tube. Here is a metal tube, so we have to boil it after cleaning under running water. After removing the inner tube from the outer tube, they have to clean it under running water, and again they can boil it. Okay, boil it, cool it, and soak it that clean with that sodium chloride like normal saline, and tap well and make sure that there is no water inside the inner tube, and they can replace it. Here, if the patient is using inner tube, you can suggest one additional, they can purchase an additional inner tube. Okay, the same size is available. The inner tube is also available for buy. So for buying, so you can suggest one additional outer inner tube for purchase the for maintaining the patent airway. So if they are boiling the if they are using metal tubes, it will definitely takes half an hour for replacing the tube. We need to cool after boiling. It will take time. So that time there could be a chance of blockage of outer tube. So better you can suggest one additional outer inner tube for maintaining pattern airway. And outer tube is not removed. We all know that we can able to clean the place, that base, the tube place with the normal saline. So come to the outer tube care. Changing the tie of the outer tube. So we can able to change the tie of the outer tube, but if there is any dirty there, you can change it. But the one important thing, so before applying a new tie, it should not remove. Okay, so if they are if you change the outer tie, so the outer tube, there is a chance of displacement there. So there is very important when we change the outer tie. So first you should place a new tie along with that old tie. After fixing the old new tie, you can cut the old tie. Okay, that way we can remove the older tie from the outer tube. Otherwise, if you irritate, if you go that irritate trachea, the tracheostomy tube, there could be a chance of cough. So if the patient is having lot of cough there, there is a chance of, if you are not fix the tie properly, there is a chance of displacement of outer tube will be there. So better you can fix the new tie first, and then you can remove the old tie. Okay. So better you here you can if they are removing the tie, changing the tie, one of the relatives or the caregiver can do that part. So come to the skin care, clean the skin and the tracheostomy to be solved. So very the tracheostomy area is very important. You can clean soak the gauze with saline and clean the tracheostomy stoma. And always you can clean that to keep the tracheostomy stoma clean and dry. And if there is a skin escoration around the tracheostomy area there, try to apply Vaseline mixed gauze paste. That way we can able to prevent skin escoration around the tracheostomy area. And for suction and humidification, here we all know that if the patient is having tracheostomy, if you are doing suctioning, if there is a lot of secretions there, we usually do tracheostomy suctioning, but it will be doing very gently and not more than 5 to 10 seconds. Okay, that is that way we can able to prevent hypoxia. And humidification is also very important. That air is directly goes to trachea. There is no way to humidifying the air. So that time what you can do is you can wet the gauze piece and squeeze well and put the gauze piece around the stoma. That way we can able to help the humidification. And if you put a wet gauze piece around the stoma, that will help to filter in the dust from the atmosphere. So that way we can able to prevent infection also. And now the stoma protector is also available. So like a net cloth, cloth like materials. So what you can do is for humidification also you can soak the stoma protector and tie it around the stoma. Fix on the stoma and tie it around the neck. So that way we can able to prevent infection, prevent dust entry, and give humidification effect to the patient also. So and come to the last part, speech therapy. You can encourage the patient to speak. They can able to speak at least 1 or 2 words. How to do it is you can educate the patient to take a deep breath and close the tracheostomy tube, the tracheostomy area, with the help of their finger, with the support of their finger, and then they can able to speak 1 or 2 words. Okay, so that is if they have pain or any maybe if they want to explain their the features of pain, so they can take a deep breath and close the tracheostomy tube with their fingers, and they can able to speak 1 or 2 words. Okay, after that again they can take after speaking 1 or 2 words, again they can take 1 or 2 deep breath and then speak 1 or 2 words. So that way we can able to develop their speech. So again we have another video on tracheostomy care. So then if you have any doubts. Yes. Yeah.
If our patient is in the home, what are the possible emergencies that maybe patient should know?
Yeah. So one is that you are asking about the emergencies, right?
If the patient is tracheostomy, if the patient is at home, what are the things we should teach them regarding possible emergencies that may come across with the patient?
So yeah, so for the tracheostomy, if you are maintaining that maintenance of that tracheostomy tubes, you have to tell the patients. The one of the important complications that might be come is accidental displacement of outer tube. Okay, so if the accidental displacement of that outer tube there, what they can do is they can take a tracheostomy tube and obturate it, and as soon as possible they can meet a surgeon. That is the that way to manage. They are not. Please tell them not try to insert a outer tube in the home if there is an accidental displacement there. So that is the only thing that can occur. And another thing is insect entry. Okay, so the tracheostomy area is always opening, no? So there is a chance of insect entry. So always cover the tracheostomy area with the stoma protector or a net cloth towel. That netted cloth they can use for protect the stoma. That way we can able to prevent this kind of insect entry. So, and the another thing is maggots. Maggots formation is also there. Always protect the stoma. If the flies are touching to the stomal area, they may lay eggs, and after that come up with the maggots. So prevention of maggots formation is also important. So these are the few things that might be developed in the patient who is having tracheostomy. Thank you.
Thank
Thank
you
you
so
for
much.
asking. Thank you. For humidification, I was telling about that. For humidification, you can use a net, that gauze piece, and you can soak well with normal water and squeeze out excess water. This is very, very important. If we are not squeeze well excess water from the gauze piece, that directly goes to the trachea. That may leads to aspiration. Okay, so better they can use netted cloth or stoma protector, and that the stoma protector or netted cloth they can soak well with normal water and squeeze it well, and then hang it around the neck. Okay, tie it around the neck. So that time not that aspiration is not happen. If there is any excess water there, it directly fall into the floor, not directly goes to the trachea. Better they can use stoma protector or netted cloth. Okay. Okay, can we wind up the session?
Yes, ma'am.
Okay.
I think they don't have another question, so we can wind up. Thank you, ma'am. Thank you for your time and patience. And everyone, if you have any doubts regarding case presentation, you can call or WhatsApp me or Vaishnav or Sheeba ma'am, anyone, or put a message in our common WhatsApp group. And thank you all. I expect all of you on the next class. And thank you once again. Bye-bye.
Thank you. Take care. Bye-bye.
Thank you. Thank you, Shiva, ma'am.
Thank you.